Oncology Center, Ministry of National Guard Health Affairs in Jeddah, Saudi Arabia. I'm very glad to be co-chairing this meeting with my friend and colleague and my go-to person when it comes to AI in healthcare, Aziz Nazar. So Aziz will introduce himself and then just introduce the concept behind this series of webinars, and then we can go ahead and get started. So Aziz, please, if you can take over.
Thank you, Ahmad, and thanks for all of you for joining today. It's such a great pleasure to be with you. It's afternoon in Saudi Arabia. It's morning in United States. So it's a great time on Saturday to be with you, and it's an absolute great pleasure to partner with Ahmad and the Saudi Society of BMT on producing these webinar series, which I think is very unique, by the way, because they're as everybody know, the implication and the application of AI in healthcare is become very important, and understanding how AI is working and how it's applied to healthcare. It's also important, specifically in hematology and heme malignancies, and to be specific in how do we apply the technology in our specialty is very important. And I can honestly tell you, this education of trying to bring that education to hematologists, it's a little bit behind. We need more. We need more education for our students, residents, fellows, physicians. How do you use the technology to advance the field? Because the impact of AI on the field will be huge. And I'm very thrilled that the Saudi Society of BMT, with the help of Ahmad and the group there, is trying to put this webinar series now, hopefully in 2025 and beyond, to bring this knowledge of how do we apply AI in hematology. And I think it's very unique opportunity, and I'm very happy and thrilled to be part of this opportunity. And what we're going to try to do is in the next, each month, we try to bring top speakers from around the world who their research is focused on the application of AI in different aspects of hematology. So it could be benign hematology, malignant hematology, mainly malignant hematology, and how you apply the technology on the ground, not just in general, but bringing those internationally known speakers and bring their experience to you. I think will have a huge educational opportunity for all of us. And we're very happy and thrilled today to have two amazing speakers who will join us today to talk about the application of AI in AML, from genomics to therapy selections. So the format of this kind of a webinar will start with the speakers, 1 to 2 speakers per session, and then probably we'll leave about a half an hour at the end is for open discussion. And what we hope from all of you is to participate, ask questions, and making more engaging, so we're all learning as we learn from these great speakers. So it's a great pleasure to be with all of you, and thank you, Ahmad, and the SSBMT for the opportunity to be with you. We also would like to thank our sponsor, AVI, who sponsored this webinar today. We were very thankful for them to make this happen. And I'll bounce this back to Ahmad to introduce the first speaker today.
Thank you, Aziz. Without any further delay, so we will get started with the clinical part of the subject. I couldn't actually find any better person to be presenting that part than my friend and colleague whom I carry so much respect. He's very, I would say, advanced and innovative in his thinking. He established the, I would say, advanced hematology services and BMT in Kuwait. Dr. Ahmed Al-Khreji, he's a senior consultant and the head of the hematology at the Kuwait Cancer Control Center. He will be talking to us about the current edge in the therapeutic and treatment of AML. So, Dr. Ahmed, the microphone is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you, Dr. Ahmed Absi, for the nice introduction, and Dr. Aziz. I'd like to extend my thanks to the Saudi Society of the Bone Marrow Transplantation for inviting me today for such a great webinar I started just looking at after the artificial intelligence like a few months ago when I did a rotation at King Faisal, where one of our colleagues, Dr. Shukri, was very amazingly doing some searches in the field of malignant hematology, asking very difficult questions, trying to answer these questions by the ChatGPT. And I would be using the ChatGPT for the first time in the preparation for my slides for today's meeting. So without any further delay, as you know, these are the principles and objectives that I'd like to cover in the next 25 minutes, the general principles of treating AML, the comparison between the WHO and the ICC classification, also an update on the risk stratification of AML, and the MRD evaluation, and also an update on the newly diagnosed AML treatment, focusing mainly on the intensive approach for the sake of time. So as a general principle, we have the clinical evaluation for new AML patients, putting the age, performance status, and comorbidities as a pillar for evaluating such patients. And at the same time, we should expedite the molecular testing, for example, FLT3, CPF, and NPM1. And at the same time, we do the risk stratification based on the ELN 2022 for the intensive therapy approach and the ELN 2024 for the less intensive approach in AML patients. Also treating sometimes some emergencies to keep it in mind for the hyperleukocytosis and blood transfusion if needed. So these are the prognostic markers that we usually look for, the patient characteristics, the disease characteristics, and the response quality, focusing on the MRD testing. As I said, the patient characteristics are basically the age, comorbidities, and the performance status to decide whether the patient would go for intensive therapy approach or non-intensive approach, meaning that he wouldn't be eligible for stem cell transplantation. The disease biology and characteristics are extremely important, focusing mainly nowadays on the cytogenetics and molecular profiling. And finally, we should not also forget the response quality while we're treating the patients when we evaluate not only the complete remission assessment, but also the minimal residual disease. Now, these are the two ICC and WHO 5th edition looking at the AML classification. These are very busy tables and figures, but I'll try to summarize it in a bit more details. So both the ICC and WHO highlighted the biologically and clinically defined relevant AML subtypes. They both defined an AML with low blast count, so they put a weight for the cytogenetics as well as the molecular. They both said that this is a patient with AML whenever they have a blast count of more than 10% if they have CPF or NPM1 mutation. However, the CEPP alpha mutation is different between the WHO. Any CEPP alpha is favorable in WHO. However, in the ICC, it's only the BZEP alteration, the in-frame alteration, that is prognostic in AML. PCR-APL, they should have a blast count of more than 20% in order to define the accelerated phase. The ICC requires at least 10% of blasts with genetic abnormalities, except for PCR-APL or patients who had a prior MPN or a CMML, where we knew sometimes that those patients with MPN, they have a blast count of 10 to 19%, but they don't behave like an AML patient. The ICC put a new categories called AML/MDS for patients who had a blast count of 10 to 19% if they have specific criteria. Now, the secondary AML was not mentioned in the ICC. However, in the WHO, they put the AML with the myeloid-related, myelodysplasia-related changes. The prior patients who had a prior MDS or antecedent myeloid disease, or specific cytogenetics and molecular operation. The secondary myeloid neoplasm, SMN, is put as a new entity in the WHO for those patients who had a prior history of chemotherapy or genetic predisposition for secondary myeloid neoplasm. Now, the therapy-related AML was not integrated in both classification because we knew that the therapy-related AML is a heterogeneous disease. However, patients with P53 or NPM1D mutation is considered to be somehow related to therapy-related and its prognostic. The DDX41 AML also has been put as like a trigger for physicians to think about the patients who had familial or germline MDS and AML. Now, in conclusion, both classification put some challenge among the healthcare professionals, especially the pathologist and the treating hematologist. We have to admit that similarities here exceeds the differences, and it is the clinician responsibility to synthesize or formulate biological, clinical, and personal data to make treatment decisions. The ICC was very aspirational, and they trying to have the molecular test within 3 to 5 days. Many centers, they're trying to do that, to have the NPM1 FLT3 at least in 3 to 5 days in order to formulate the treatment plan. So just to give you an example of a 51-year-old man who was previously healthy, who had pancytopenia, WBC 0.5, platelet 42, and plus of 5%. The bone marrow showed a 12% plus, and the bone marrow cytogenetics was trisomy 8. The myeloid gene panel was negative. So if we look at the was he an MDS or AML, the ICC put him as an MDS/AML with myeloid dysplasia-related cytogenetic abnormality having trisomy 8, while the WHO would put him as an MDS alone. Now, the risk stratification, we knew that the ELN has put some risk stratification in 2022, and the classification here, they introduce many molecular testing in the adverse cytogenetics, the ASXL1, SF3P1, etc. However, the FLT3 is not adverse risk group anymore. It's intermediate, irrespective of the allelic ratio or NPM1 mutation. So I'll give you an example of a 43-year-old man who has normal cytogenetics, and he had 8 mutations on the myeloid gene panel in our center. So he had 2 CAPP alpha. One of them is the in the BSEP domain. It was an in-frame biallelic alteration. However, he has other mutations called ASXL1, IDH2, KRAS, JAK2, FLT3, IDH2, and DNMT3A. So it is really difficult to put this patient as a favorable risk, having all these other molecular profiling. And we had a chat at that time in the last summer with Dr. Donor. So how would you fit him in the classification for ELN 2022? It was really an interesting question, not being able to classify him, but at least this patient would not be a favorable risk AML. Now, for the patients who had a less intensive approach, we knew that the AZA venetoclax has changed the field of AML, and also the AZA ivosidenib. The adverse risk group is only the patients with P53, and they also looked at 3 signaling activating mutations called FLT3, NRAS, and KRAS. If you have any of those without P53, this is intermediate. Other patients, NPM1 with no activating signaling pathway mutation or P53, IDH2, they are favorable. The mutated IDH1, irrespective of the activating signaling pathway, but they should have a P53 wild type. They should behave well if they were treated with azacitidine and ivosidenib, an IDH1 inhibitor. So the treatment approach in ELN 2022, they put the FLT3, non-FLT3, CD33 positive, favorable, intermediate, and therapy-related AML, and with MRC. The midostaurin will be incorporated in the FLT3 mutant AML. The oral azacitidine will be incorporated in the maintenance. The CD33, if they were favorable or intermediate, the gemtuzumab ozogamicin, the antibody drug conjugate, would be also added in the induction. The question whether you give it 1 or 3 doses. Most of centers, including our center, we give only 1 dose, and we try to give 2 doses in the 3 or to 4 consolidation. In all categories, we have to assess the MRD in order to say whether the patient would be eligible for allogeneic stem cell transplantation. The NCCN guidelines also put the 3+7 plus GO is for the CPF AML, the one with core binding factor leukemia. And FLAG-IDA was put in the category 2B. I know there are many centers and many physicians would argue against the 3+7 in the CPF AML. However, in our hand, it's very toxic. Maybe you're losing more patients than we're benefiting. The AML with favorable risk group or intermediate, the NCCN did not put the GO as a preferred regimen. However, there are growing evidence now that the GO would be better for those patients. For the FLT3 AML, the midostaurin or quizartinib, which is only active against the FLT3 ITD, in addition to 3+7. Talking about the poor risk, here we're talking about either the patient had P53, 17p deletion, then the patient would be eligible, possible to a clinical trial to enroll them. Otherwise, then you have to choose among many chemo versus less intensive approaches, and there is no preferred regimen in this group of patients. Ultimately, you have to take them to transplant those poor risk adverse risk group AML once they achieve remission. Now, I summarized this busy table just to show you that the gemtuzumab ozogamicin has been used in the patient who has NPM1 and other AML 15 and 16 trial, and also the Alpha 0701, which showed that there is a benefit in mainly patients below the age of 50 and favorable intermediate risk. The AML 15 also showed a favorable benefit in the favorable risk, and also there was a trend in the intermediate risk AML. That's why the GO has been incorporated in the favorable intermediate risk AML induction as well as consolidation. Another medication that is in the pipeline is the ziftomenib. That is a menin inhibitor approved in the relapsed refractory AML. It granted a priority review for newly diagnosed AML with NPM1 mutation based on the data presented at the last EHA and ASH meeting. Now, looking at the NPM1, if we look at the frequency of NPM1 among the Kuwait experience of 153 patients, we can see that the NPM1 represent 32% of the our cohort, and it matches with the international, I would say, data where you have 30 to 35% NPM1 mutation in AML. Now, for FLT3 AML, we have two landmark studies, the RATIFY and the QUANTUM trial. This is the 10-year follow-up of the RATIFY trial, where they gave midostaurin in addition to 3+7 in a randomized fashion. The primary endpoint here was the overall survival. At 10 years, the median OS was 67 versus 43, 25 months, favoring the use of midostaurin in AML. They tried to look at among the various subtypes of FLT3 ITD. It showed that overall it is showing preference in the overall, but there is no FLT3 low or high or TKD. They would do better than the rest of the patients. Also, the quality of the remission when patients treated with the midostaurin, if they go to transplant in CR1, they show that there is a trend toward the better outcome when they go to allogeneic stem cell transplant under the coverage of midostaurin. So I'll skip this slide, and also there are some mutations that seems to be prognostic. Is the NPM1, the secondary AML mutation, showed a benefit from midostaurin, and also there was some gender variability where the men, they did much better than the women, with a hazard ratio, as you can see here, is 0.8 versus 0.81. The QUANTUM first trial looked at the 3+7 in addition to quizartinib, but the patients would receive quizartinib here not only for 1 year after the completion of chemotherapy like the RATIFY, they will receive it up to 36 cycles, which is 3 years. Same primary endpoint and secondary endpoints. We can see that the CR rate was and CRI was higher in the QUANTUM first, 71 versus 64. We can see also the hazard ratio was 0.78. The median OS was in favor for quizartinib use at 32 months versus 15 months. and the CRI was better. But we have to keep this in mind that the quizartinib is only active against the FLT3 ITD, but not the TKD. This is subsequent sub-studies from the Quantum, it was presented in the EHA last June, where they looked at different mutations they tried to see. It turns to be that NPM1 and other epigenetic modifiers such as DNMT3, TET2, WT1, they showed better responses and better overall survival when comparing to other patients who had no mutations. Now, here I use the ChatGPT just quickly to summarize and compare the quizartinib and midostaurin. You can see that the QT prolongation was higher in the quizartinib. It's been used in the post-transplant setting. However, the midostaurin, if you remember, the study of the RATIFY, those patients who had transplant, they wouldn't be eligible to get midostaurin in the maintenance approach. Now, another interesting study published last year in the Blood from the BATHEMA group looking at 284 patients. And this study was to give quizartinib for patients who was FLT3 ITD negative AML. And the median follow-up was 39 months. It was given in a randomized fashion. The interesting part of it that the median of OS and event-free survival wasn't favorable of the quizartinib use. And the biomarker of having such a better responses was the NPM1 and other patients who had the FLT3-like gene expression signature. Now, looking at the azacitidine and venetoclax, this is the long-term follow-up of the VIALE published in the American Journal of Hematology last year. You know, the VIALE-A used azacitidine as a comparator in addition to azacitidine and venetoclax in the study group. So the primary endpoint was the OS, and as you can see that the CRI rate was almost double, 66 versus 28%, and the median time to response here is 1 cycle with a significant p-value. The median OS was favorable in the AZA-VEN, 14 months versus 9 months in the AZA alone arm. We can see that the P53, they have 55% response rate versus 0% with the azacitidine alone. And the transfusion independence was higher in the AZA-VEN group as well. The MRD negativity was also prognostic in the VIALE-A. As you can see, that those who achieve MRD negativity, they can have almost a 3-year median overall survival with AZA-VEN and 25 or 2 years in the AZA alone if they achieve MRD negativity. Now, there was also an analysis of the IDH1/2 mutation. They do better with the azacitidine and venetoclax, but turns to be that the IDH2 is the group that they do much better with the azacitidine and venetoclax. This is again the patients who are receiving AZA-VEN. This is the same study where the ELN 2024 classification for the risk based on. They looked at the patients who had AZA-VEN and they looked into 4 mutations, the P53 and KRAS and RAS FLT3 mutation. Anyone who has more than 2 years, there will be a favorable risk. Anyone below 6 months survival would be an adverse group. So only the P53 mutated AML would be eligible in the adverse risk group here. The VIALE-A safety, as you can see, very high rate of, as you know, the neutropenia with the AZA-VEN. Many patients, they might have some toxicity and also early mortality within 30 days, 7 versus 6%. So we have to be vigilant about the early mortality, even with the azacitidine and venetoclax early on. The hematologic toxicity, as you know, very high rate of neutropenia, 43% versus 19%, but this did not translate into a higher rate of infection. As you can see here from the table on the right-hand side, the sepsis rate was 7% versus 8% in the azacitidine alone. Now, among the responders, you can see that many patients, 67%, achieved the response, and the median number of cycles they had received is 13 months. Now, the median duration of the cycle is 34 days, and most of the patients, they would stop the treatment for at least 2 weeks or a median of 2 weeks in order to have the second cycle. So in our hand, we give the first cycle, depending on the patient age comorbidities, between 14 to 21 days, and we try to escalate the therapy down whenever possible. Now, very quickly about the AGILE study, the ivosidenib, we know that the IDH and IDH2 mutation, they have an accumulation of the 2-hydroxyglutarate, which stop the differentiation of the myeloid cell, leading to acute myeloid leukemia. In our center, we have almost 18% of IDH1 and 2. IDH1 was 8% almost, and IDH2 is 10.5%. Now, the AGILE looked at the azacitidine plus minus ivosidenib, 500 milligram daily, and the primary endpoint was the event-free survival, and the secondary endpoint was the overall survival here. If we look at the early follow-up of 12 months, the event-free survival was in favor of the ivosidenib, having less treatment failure and less relapses and death. So there is a hazard ratio of 0.33 and a significant p-value. The overall survival was 24 months in the AZA-IVO versus 7.8. And the new update with the 28 months, we can see that the median OS was 9 months, actually, 2.5 years versus 7.9 months. Now we can see also the complete remission rate, and is almost 53 versus 18%. So, and also we can see that the treatment adverse events related, the differentiation syndrome was there, happening in 14% versus 8%, and QT prolongation. The infection rate were less common with the AZA-IVO versus the placebo. Now, this is the reanalysis from the AZA-VEN study, the VIALE-A. You can see that the IDH1 mutant is 10.2 months. If you compare this, however, we should be very careful about the cross-trial comparison to the AGILE, which is 29 months now, and the IDH2, they have 27 median overall survival. Now, these are the differences between the AGILE and the VIALE-A. You can see that the median age was comparable. The sample size was 146 in the AGILE versus 430 in the VIALE. The median OS was 24 in the AGILE, and maybe it's better now with the new update, it's 29 versus 14. The MRD was not an endpoint in the AGILE, however, it was 23% in the patients who were responders. So the maintenance therapy, just summarized in a small table, we have the oral azacitidine, we have the enasidenib and ivosidenib, we have the 3 FLT3 inhibitor, the midostaurin, gilteritinib, and quizartinib. The one that is approved is the oral azacitidine by FDA and EMA, the midostaurin by the FDA as part of the full regimen. The quizartinib is still, gilteritinib is still an off-label, but many centers have started using it, especially with the AZA-VEN and the gilteritinib. The quizartinib has been approved by the EMA, but rejected in the FDA. So finally, the MRD should be a surrogate endpoint for AML therapy because it correlates with the overall survival and disease-free survival as based on this large systematic review by Nicholas Short. You can see that among all patients, whether adult, pediatric, the MRD assessment at any time point was in favor of overall survival and DFS. And whatever method that you're using, whether it's a multi-parameter flow cytometry or PCR or NGS, we have to be okay with that. But the cytogenetics, you can see it's matching or touching the one line here. Now, MPM1 is being used in our center. Now we have data from the AML 17 and 19, around 730 patients, MPM1. they showed that the survival here is in the range of 80% versus 40% for those with NPM1 positive post-induction. So I think we have to strive to have those patients to transplant if possible, because they would relapse in almost 75% of the cases. Also, it was prognostic in the ESA-1 treated patients after 4 cycles. The MRD negativity was also prognostic in the overall survival and relapse-free survival. The unanswered question here is the time point, the level of detection is, or limit that you're using, saying this is negative, positive, the method, the accessibility, and the source, whether you need to do it from the bone marrow. And many patients would hate that. However, if it's possible from the peripheral blood, that would be an ideal site. The ELN 2022 also put some recommendation about the NPM1 CPF. When do you need to do it? I'll leave you with this table and figure. However, in all other AML patients, you have either multi-parameter flow cytometry using a leukemia-associated immune phenotype or DFN, or different from the norm, in order to say whether this patient achieving MRD negativity or not. Finally, as if you have a frontline AML below the age of 60, a fit patient, if he has CPF or NPM1, the best way is to go for intensive chemo plus GO, FLT3 positive AML, intensive chemo plus FLT3 inhibitor. Therapy-related AML, you can choose any of those, whatever is available. CPX is not available in our country, and maybe in many countries in the region. The P53 or complex karyotype, you may use HMA-V followed by transplant. Now, the post-remission would be based on the MRD. If they were positive, then and they are fit and they have a donor, they should go for transplant. They're negative and the I would say CPF, FLT3 therapy, either related, you can continue on chemo. The high risk, adverse risk group, they should go for allotransplant. With that, I conclude, and thank you so much for listening.
Thank you very much, Dr. Ahmed. An excellent talk as usual. I'm not really surprised. And I think it sets the stage excellent, I mean, in a perfect way for the second discussion and then the second presentation and subsequent discussion. So, Aziz, if you can take over from here.
Thank you, Ahmed. And thank you, Dr. Ahmed, for the great presentation. It was amazing to review all the landscape in very short time, put everything in AML. So that was a great, and we loved it. So it's really my great pleasure to introduce Jan Medek to present the next presentation. So Dr. Medek is a specialist in internal medicine and hematology and oncology. He heads the outpatient clinic of the Department of Internal Medicine at the University Hospital of Dresden, one of the largest centers of hematologic malignancies in Germany. He's the medical director of several large phase 1 and 2 trials in the field of AML, and a reviewer for high-impact journals such as Lancet Oncology, Blood, and Leukemia. His scientific interest is therapy optimizations of acute myeloid leukemia, with a special focus on the integration of novel technologies. He's the leader of the working group Artificial Intelligence in Cancer at the University of Dresden Hospital and the Elsa Kroner Center for Digital Health. The group uses state-of-the-art computer vision to improve accuracy and usability of cancer diagnosis and machine learning to leverage the power of big data in cancer research. He's also a co-founder of 2 startups in the field of medical AI. So it's such a great pleasure to have Jan here with us, and we look forward to his presentation.
Yeah. Hi, Aziz. Thank you so much for the introduction and for the invitation to the Saudi Society of Bone Marrow Transplantation and all of you to listen. And as said before, a very great talk, and I think it perfectly sets the stage for what to come next. And really excited to talk about AI and AML. And so I have a lot of data. So the idea is that we go through it quite quickly due to the limited of time, but then afterwards we have quite a lot of time to discuss it, and we can also then go back to some data and look at it in more detail. So here are my conflicts of interest. And as Aziz said, I'm a co-founder of two startups doing AI in the field of hematology or medicine in general. So I will talk about AI for diagnostics, for risk stratification, and also about the use of large language models, which is getting more and more important in daily routine, I would already say. So the reason why we need help is basically what we've seen before. And this is just acute myeloid leukemia. And we just saw how complicated it is already with the known evidence we got about like risk stratification just based on the available data we have already. And that's just like a part of what we have in terms of diagnostic procedures. And so the medical knowledge is doubling so quickly right now, and here are some figures quite recent. 3 days, it doubles every time, so this is really increasing. And then there's of course a shortage of healthcare workers in the world, and of course medical errors are a big issue. So a lot of people, a lot of doctors believe that AI will substantially influence how they make decisions within the next years. So we have to deal with it, and we have to talk about these things and try to understand how we can use them. So just briefly to just summarize some of the words we use. So when we talk about AI in general, we basically mean like subtypes of machine learning. And for the most advanced task and what really advanced the field in the last years is deep learning. So a subset of neural networks, and there are these transformers which are used for like ChatGPT and so on, and CNN, which really paved the way for the progress we had by using computer vision. And the idea behind that is that when we use conventional programming, so we stay with AML, we took a large data set of AML patients, and then we ask, okay, we know TP53 has an impact in other cancer types, so does it have an impact in acute myeloid leukemia? To have a TP53 mutation, yes or no? And then we saw the result in terms of a Kaplan-Meier curve. And what machine learning is doing is that we give the data to the computer and say, okay, here's the data, here's the outcome, look for patterns, and then we can give in new data, and the learned patterns get applied, and then we get the results out of that. So starting with AI for diagnostics. So when we talk about acute myeloid leukemia, we have several important aspects or areas of diagnostic procedures we use. And I want to start off with cytomorphology and cytogenetics. And so the idea and what has really been a problem for such a long time is that a computer can dissect these things we as a human can do easily, to dissect what we can eat and what is a dog, and here what is a croissant, and so on. And this problem has been solved a couple of years ago by computers. And translating this to medicine, the idea is that the genotype of basically everything determines the phenotype. And now using AI, we can go back from the phenotype to get information about the genotypes. And this is also working in hematology. And I just want to give you a brief example. We heard about still the importance of blast counts. So we do the bone marrow punction. And then we do a manual counting, come up with a myelogram, and this is of course done during all the course of the diseases. And there are several problems with it. So you're familiar with it. There's a variability between certain examiners. It goes up to 30-40% if we take the same staining, the same smear. There's a lack of standardization. It's time consuming, and it's really hard to learn that. It's really hard to become an expert there. So that's an excellent field to apply computer vision, and there are basically two ways how to tackle computer, or like to bring into computer vision in heme diagnostics. So one could look at single cells and label them and train a model with that. But we can also like train a model just based on the whole smear and say this is MDS or this is like ALL or AML, and then train a model with that. So a couple of years ago, we did this in one way to first ask the question: can we detect acute myeloid leukemia just based on the bone marrow smear? We digitalized a large cohort of acute myeloid leukemia patients, 1,200, and had a control group of real healthy bone marrow donors. And yeah, then we trained a model with that, built a pipeline, and asked as a first question, can we detect acute myeloid leukemia? But then we thought of, okay, can we detect also certain mutations? And as we've heard before, NPM1 is one of the most common mutations. So we ask whether we can detect this mutation. And here you see the results. So for the, let's say, easy task, we can detect acute myeloid leukemia compared to a healthy bone marrow just based on a bone marrow smear. But we can also predict the NPM1 mutational status with a very high accuracy given here. And even more important, we can make this explainable. So here you see the original picture from the bone marrow. And here you see so-called occlusion maps. And an occlusion maps works like this. So you basically take out one small area of the picture and see how the performance of the model drops. And then you can say, okay, this area is more important compared to this area to predict, in this case, being NPM1 positive or NPM1 negative. And then you can go back and it really makes sense in terms of the biology when you look at the NPM1 protein, how it's shuttling and so on. So yeah, really important to make the models explainable to understand where the results come from. This has been shown subsequently for other mutations, other cytogenetic abnormalities, and also what I want to highlight here. So you don't need like a huge number of patients anymore if there's a strong effect shown here for PML-RARA, for example. So you can do this for like a lot of cytogenetic abnormalities and mutations just based on the bone marrow smear. This also works in pathology, so bone marrow histology, and here the colleagues also looked for like certain mutations, but they also asked for like AML transformation and overall survival, and you can see here that the results differ substantially. So for certain mutations, it really works well, TET2, ASXL1, some monosomies, but then there are of course difficult tasks like complex karyotypes and acute myeloid leukemia transformation, where it is more difficult. Not everything is understood, not everything really makes sense, at least to me. So I would have said that secondary MDS and so on would be more easier to detect or to train a model with it. But in general, the message is it also works for bone marrow histopathology. So we went one step ahead and asked whether we can like predict response to a certain therapy, and we did this together with Dan Pollier from Denver, and looked at a cohort of 170 patients with newly diagnosed acute myeloid leukemia treated with Ven/Aza. We saw it via the data, and then took the bone marrow smear and trained a model based on responders and non-responders, asking whether we can predict the response to a certain therapy or not. And here are the results. So it worked really quite well. So over 80% ability to predict response to Ven/Aza just based on the bone marrow smear. And yeah, you've seen the data before where the genetic model is able to predict responses. So we're currently combining this. So the idea is, and I strongly believe that we should incorporate everything we got and try to identify those patients who will benefit the most. And because you've seen it before, this therapy is also not non-toxic. So it really makes sense to really identify patients who have the biggest or the highest chance of benefiting from a certain therapy. So, and as I've said before, so one of the spin-off companies is CanSilico, and there we developed Myeloate, and this is just a short video to show you how you can use this, so an AI-trained model just for getting the automated myelogram. And you can see here, so the model looks at the certain areas which are good to evaluate, and you can like pick them, or it does it automatically. Then you get all the cells in the area, you get the labels for one single cell. You can also like correct them if you don't agree, and then it comes up with a myelogram as you are used to it. And of course, the model, doesn't matter if you count, like in this example, 700 cells or 2000, and it's reproducible and so on. So it's really working quite well. The next thing, karyotyping, super important. You've seen this for the risk stratification. And again, here we can use AI to do the job. So here are the results shown for a model. This is one single chromosome here. So you see some outliners, but in general, it really, really works well. And again, a short video here coming from the MLL, one of the large leukemia labs in Germany. And what you see here is on the left-hand side, the most experienced technician doing a karyogram. And this is like really, if you're familiar with it, this is super fast, super precise. It's really hard to beat as a human. And then on the other side, you see their AI-based model. And this is now really also applied in routine diagnostic. It's working also for the more complex cases with complex karyotypes and so on. And as you can see here, these are the results. So the best human needs roughly 40 seconds, and the AI-based model only takes 12 seconds. So this is a future that we can like really automate a lot of the diagnostic steps we are doing right now. So I covered this area: cytomorphology, cytogenetics, immunophenotyping. You heard about this before in MRD diagnostics. And again, here, just really briefly, this also worked really well, dissecting between acute myeloid leukemia, acute lymphoblastic leukemia, and again here you can also predict like certain subtypes shown here for APL and so on. So this really works also well using flow cytometry, and like integrating this and like comparing it to certain criteria we know we use already, like primary and secondary acute myeloid leukemia. We can reclassify these just based on the genetics. A large group of patients, roughly almost 7,000 acute myeloid leukemias, and just looking at the genetic signature, we can do 4 distinct groups. And of course, they differ in terms of their molecular signature, but most importantly, they really significantly differ in terms of overall survival. So just based on the genetic profile of that. This leads me to the next chapter, talking about AI for risk stratification. And of course, what we do as doctors every day basically is taking account all the things, all the information we got about a patient. So we have a lot of data, molecular data, cytogenetic, but also clinical data, and then pathology, radiology, and so on. And of course, a clinical look at the patient. And then we can do a lot of AI methods to do basically what we do in our routine. So prognosis, risk stratification. Based on that, we do a treatment selection, and ideally we also gain novel biological insights. We did this for AML a couple of years ago. Took everything basically what we had about our patients, and then asked the question, can we identify patients with a high risk and a low risk? So we took 1,400 patients from our clinical trials and took everything we had in clinical data, laboratory results, LDH and so on, white blood cell counts, all the genetics, molecular and cytogenetics, and all the like raw data, not like pre-filtered, and then applied different machine learning algorithms. This is an important thing. So there's not that single perfect algorithm you can use for every data set. So you basically have to try different algorithms, and also sometimes have to combine them. And then the model comes up and we ask, can we predict complete remission and overall survival as being like very important endpoints in acute myeloid leukemia? And what the model comes up with is like, on the left-hand side, you see the features selected by the algorithms. And of course, you see features we already know. If not, this would have been like really surprisingly, but and also it makes a lot of sense that age has such a big impact, it also has to be identified by a machine learning model. And then on the right-hand side, you can see the impact of the certain items on the complete remission rate. And again, here you see factors we already know, A21 and so on, NPM1, where we know that they have a good prognostic impact. But we also gain informations about molecular alterations or findings where it's not so clear and there's conflicting data out there. And something even surprisingly, IKZF1. I didn't know IKZF1 played a role in acute myeloid leukemia back then. It's also a different type of mutation compared to ALL, where it's quite well described. But for AML, it was completely new to me, to us, and we were quite luckily that it was just included in the myeloid panel we used back then. Otherwise, we wouldn't have looked at that. And so we thought, okay, IKZF1, this is quite interesting. So we went back to the lab and looked at another cohort of patients and did some wet lab research. There's a clear hotspot mutation for this. There's a distinct co-mutation profile of this, also a distinct gene expression profile in RNA sequencing. And most importantly, even in multivariable analysis, this is shown here, there's a strong prognostic impact on overall survival. And this is for me a perfect example how we can apply AI for large data sets to really gain novel insights and identify subtle mutations. And of course, this is rare, but this is similar to inversion 3 or something like this. So it's rare but recurrent. And so it plays a role and paves the way for a really personalized way how we can identify certain patients at risk. We used the same data set for an unsupervised clustering method. So we just took the data in there and set the model, okay, try to identify clusters. And the clusters should be as similar as possible within one cluster and as diverse as possible between the certain clusters. And what the model then comes up with, similar to what I've shown before, are here 4 clusters. Again, a distinct molecular profile, and you see things we already know, NPM1 corresponding to normal karyotype and so on. But then we have a strong prognostic impact of these risk groups, and then one could say, okay, this is what ELN does, but when you look here, there's a substantial number where the patients get reclassified. For example, looking at here the best cluster, cluster D. Of course, the majority of patients is ELN favorable risk group, but there's a substantial group of patients having intermediate or even adverse risk, and vice versa for cluster B. Half of the patients are good risk or intermediate risk, and they really have a poor prognosis here. So if we put in more data, it helps us to do a better defined or a more precise risk stratification. That's the basic idea. And this has been subsequently shown also using other cohorts, older patients all treated with intensive chemotherapy. And again, they did some clustering and then found, again, factors we already know to have an impact and come up with a model. And again, they were able to really reclassify the risk stratification coming from ELN 22 according to their model, again showing that we can do a more precise risk stratification. What this group of colleagues did is really something I really found really interesting. They just took 800 data from 800 AML patients and then did group them according to an adverse group, died within 12 months, intermediate, and favorable, survived longer than 60 months, and then looked at these groups and looked for the factors which are more important to, most important in these groups. And again, They compared it to ELN and come up with an ensemble model where whenever like the two models predicted something different. And again here they were able to really show that the combined model is much better in predicting the outcome, and then you can like stratify this for the certain risk groups, and it works really good for all the certain groups. I'll skip this a little bit. Yeah, last thing for molecular genetics, we've heard that before. So NPM1, TP53, and so on, they really play a crucial role. However, we now take mutation being there or not. We already know that for at least for MDS is clearly shown, TP53 mutation 1 or 2 or more really matters. So we have to, it's and of course we know this as doctors. It's not so easy having like one mutation or no. And what we looked here at is the impact of age. We know this for NPM1. It's really a favorable prognostic impact is clearly shown for people below the age of 60, above of the age of 60. It's really like the data is not so clear, and the rationale to think that this might be true for other mutations is also there. So. But this is really hard to study because age itself has such a high impact on overall survival. So with conventional statistical method, it's really hard to decipher this for like all of the mutations. So we looked at this together with a colleague from Seattle, like spanning the whole lifetime, also including really infants to really old patients. And then you can look for each single mutation or cytogenetic abnormality. And what you see here using the SHAP values is how high the impact of this certain mutation is within a certain age group. And then you can like really narrow it down and say, okay, we've already seen that before, but you can do this for all the other mutations. It has a strong prognostic impact if you're young, and it basically is gone if you're older, or is even changing with according to age. So again, we have to we have to acknowledge that AML and other malignancies are so complex, and it's not that black and white mutation there or not. So and there again, machine learning can really help us. So really quickly in the last minutes, I will briefly talk about large language models. And so large language models are there. They will substantially change the way how we do medicine in the future, how we treat patients. And of course, we have like a part, and we've seen perfect examples before, summarizing clinical trial data, compare them, and so on. It works perfectly with ChatGPT and so on. However, when we like really want to get like treatment decision, treatment recommendation, and so on, we really have to trust them. And there, RAG, retrieval augmented generation, is one technology to basically tell a large language model what sources to use for their answer. And this has been shown here in a work just recently being published in Nature Cancer. So basically, we asked how should we treat a certain patient, and we put everything we got in there. So tabular data coming from the electronic health record, but then also like the original histology, original radiology data, and then took certain agents using like or answering their part of the question. So we had one for like looking at the pathology, one for the radiology report. Then we search PubMed, OncoKB, and so on. And then we said, okay, based on that information, now look for certain guidelines and give us an answer for how to treat this patient. And then you come up with results which are really, really good. So they're correct, they're complete, but you can also like go back to the citations. Where is your recommendation coming from? And so really showing how we can bring trust into how we come up with decisions. And this is just from the paper a more nuanced example where it really gives you the certain therapy, and also like talks about like certain mutations, also identifying some discrepancies within a written report and so on. And this has now been shown for several other like use cases for the New England Journal Clinical Pathological, like really difficult clinical cases. And here you see the human also using like Google search, and a lot of large language models are now outperforming them. And this is also shown for diagnostic reasoning and so on. And you can basically find this for every single use case. Here is some other Nature Medicine work just published this year for pulmonology, endocrinology, and also you can like see the benchmarking of the AI against like junior doctors, but then more advanced or senior doctors, and it's almost as good as the senior doctors. And so this is like the Synergen chatbot. It's using the German guidelines, so we had to tell them like provide the answer in English, and then you see for FLT3 mutant AML having a relapse, and then you get gilteritinib based on the data, and then it shows you where the citation in the guideline is telling you how to do this. Also says you, okay, there are open questions, optimal sequencing, and so on, and also the level of data and so on. Very important. Large language models should be used as a scientific reason engines, not knowledge database. So this is what I've shown you before. We have to basically tell them what knowledge database they should approach. And yeah, so I just put it in before because it was mentioned. This is also working for clinical trial matching, and there's a lot of ways how to do this. This is like an end-to-end approach, really putting up an electronic health record into a large language models, connected to clinicaltrials.gov, and then they are really looking at each single inclusion-exclusion criteria and from unstructured data, and then really telling you, okay, based on the also like the area you're in, 50 kilometers to 100 kilometers or whatever, it tells you how to get there. And then it also like explains to you, okay, I didn't have information about like the written informed consent. I can tell you if this criteria is met or not, of course, making sense, and then you can put them in there. And this is really working well for the majority of clinical trials. So I think due to the sake of time, I will skip the synthetic data part and just here, so it also works for images. Some of them are fake and some of them are real. I just show you, and yeah, also like I haven't got time to talk about like research, but also there's so much happening. There's a virtual lab, and it's really like doing all the experiments and doing the whole thing. So Gen Bio AI. So basically coming from the molecular level to the pandemic. So really a lot of yeah, really cool and interesting stuff ongoing there. Agents are really changing how we will use AI. And with that, I'm finished. Thank you so much for listening, and thanks to all the people working with me, Jan Eckert, who's been doing a lot of this work, Jakob Carter, a really good friend and close collaborator, and also the people from the US. And yeah, thank you. Really happy to discuss this with you.
Thank you very much, Jan, for the excellent talk. It's really amazing and a lot of information, and was beautifully illustrated how AI could be applied into different aspects of taking care of patients with acute myeloid leukemia. So what we hope to do now is really an open conversation and discussion with the speakers. So first, I would encourage all of you, if you have any question, just put it please in the chat for both speakers. And maybe Ahmed and I can start with some of the question. First, I would like to start with Dr. Ahmed. you put a very, very nice and interesting case that illustrate, in my opinion, the difference between the guidelines, especially the ELN guidelines in genomics, and what you see in the clinic. The CBP alpha with multiple mutation. How do you diagnose that, and how do you provide the prognosis to the patient? And to be honest, this has been my puzzle for my career, because we try to simplify, right? We say NPM1 positive, they are good AML, but we know, and several studies have shown, the number of mutations have significant impact on survival. If you have NPM1 and the NMT3A and a FLT3, those actually do worse than complex cytogenetics. So I think I've seen this a lot in the clinic, and I don't know, maybe from the guideline perspective, it makes it easier for people to digest, but maybe it's harder for us in the clinic to kind of apply those guidelines and provide the right prognosis. So how do you navigate that in the clinic? Like, what did you tell your patient with the CPB alpha double mutant with all these mutations?
It was really tough, actually, an interesting case. When they told me that he has 8 mutations, I said, what? 8 mutations? What? So when I looked at the report, so what to do? You can't apply the guidelines here. I went to the one who wrote the guidelines, Dr. Donor, what do you do here? He said, I don't know. But honestly speaking, that definitely the guidelines there is to guide you, but sometimes, not to force you. And so you have to navigate and try to mix and match and try to do the best here. So having other mutations, KRAS, ASXL1, FLT3, you can't ignore them. And you have to tell the patient that, okay, that you have a good molecular signature, but at the same time, you have others that also may play a role here. So we have to do the best possible and to have the benefit of doubt, and then to take to transplant if you have a donor, especially that the patient was young, and we try to see whether was there a reason why he had these like bunch of mutations. In fact, we don't know the reason. So yeah, so we tell him that we have mixture of mutations, but we have like more bad ones, so we have to take you to transplant whenever possible.
Great.
Yeah.
Jan, in your experience, how do you deal with something like this, where you have, you using AI and using all traditional statistics, we know that the number of mutation correlate with survival and outcomes, especially in the intermediate segment. So how do you navigate something like this, where you have NPM1 positive mutation, but you have maybe 5 other mutations? Is that favorable risk or not? Do you transplant this patient or not?
Yeah, exactly. So basically, it always comes down to that point. So we would have to discuss this with the patient, that we just don't really know it, how to like incorporate everything we got there. And at least for NPM1, the good thing is that we can really use this as like an MRD marker, and that we can at least take into account the dynamics of the MRD count. But in general, I would say for that patient, we should go for an upfront allotransplantation. But to explain to the patient that we have to be aware of the limitations about the data. And as you pointed out, so we have to take into account co-mutation, number of mutations, but also like age. We know that sex also plays a role there. And of course, then all the prior treatment also plays a role. Is this like after Ven/Aza in first line? Does it make sense there or not? Or like there's so many things, and it's not so easy to really. It's not the black and white thing. So yeah, totally agree. Really complicated case.
I mean, you also opened another interesting struggle for me for patients with AML is and Dr. Ahmed talked about this. So MRD is important, and I think the method that we detect MRD is also important. So when we talk about NPM1, do you do PCR? Do you do multi-flow? But the same thing with CPB alpha or FLT3. Now, for somebody who has all those mutations, how do you monitor the MRD? And I know I'm asking very hot questions here. That's very difficult to answer, and it's not the purpose. What I'm trying to say is sometimes, for reasons we try to simplify, obviously the algorithm and the guidelines and all of this stuff, and the reality on the ground is much harder. Because if you have multi-flow, you could do that, but that doesn't mean that the mutations, let's say you have 60 mutations that are gone on the, at CR or after, let's say, consolidation therapy. And then if you have multiple of those mutations, do you do next generation targeted deep sequencing as monitoring for MRD? But then that's also open another can of worms, because then your test, let's say in Kuwait, is completely different than my test in the United States, completely different than Germany in terms of how much the level of detections of MRD in the next generation targeted deep sequencing. Not to increase the complexity, your panel could be 30 genes, my panel could be 325 genes. So by definition, I could detect more mutations compared if I run a panel of, let's say, 35 genes or 40 genes. So Dr. Ahmed, in Kuwait, what is the size of your panel?
Yeah, we started the myeloid gene panel in 2020. We started with around 50 gene panel, and then we ended up now doing the 146 gene panel.
And have you seen differences in terms of like you picking up more mutations, or?
Yes, we're picking more mutations once we upgraded the gene panel to 146, because I think they started initially with the DNA-seq, and then they started DNA and RNA-seq. So that's why the panel was extended.
And then the question, obviously, is that extended panel, did it add benefit or really not at all? Like for you clinically?
Well, we're looking like, we're looking at different like specific mutations, looking at, for example, the FLT3, NPM1, P53 mainly, and but sometimes you have other mutations that is there. DNMT3, SXL1 also plays a role here. So it did not add much to the clinical part, I would say.
It's fair.
Dr. Jan, just I have a question. With these co-mutations that Dr. Aziz and the case that we illustrated, do you think that the AI might help us to navigate through these multiple mutations, and then we try to like ask difficult questions to see how do they behave and interact between each other?
Yeah, well, and that's like the most important questions, and there right now I'm not really sure because all the data we have so far is based on decisions we made in the past, based on recommendations we had back then. So we treated patients with FLT3 ratio back then, if it was high or low, differently. So if we now look at the data, we look at data we derived from like certain treatment patterns we had back then based on data we had back then. So this is really difficult to, integrate this into like clinical research based on old data, and then it gets more complicated because we didn't use FLT3 inhibitors like 15 years ago, but we look at the data and so on. So this really needs to be translated to like the biological and again wet lab research to answer these questions. How will one clone respond to a given therapy? And I think there AI can really substantially increase our knowledge and seeing how we can approach these questions, because I think we really have to go back to the biology rather than looking at really old data where so many treatment decisions are already in there. So yeah, forward looking definitely, looking at the biology, simulating how how the mutations interact, cooperate, and how they make a cell more suspicious to certain drugs.
If I may jump here real quick, I think one of the important things, and it also, as I said, I think this is one of the most important things that fascinates me is the issue when it comes to risk stratification. The traditional risk stratification for AML is still heavily depends on the ELN categories. But if you think about real world, there's no such thing as one size fits all. And in reality, when we talk about risk stratification, I think we always should keep in mind that the model that is truly applied is what I call dynamic risk score, which changes based on which step of therapy the patient is in, as well as other factors that are very hard to measure in the traditional risk stratification model. And I think, or at least I would like to hear, how do you think the AI models would, by combining imaging, genetics, MRD, response data, patient characteristics, can generate those dynamic risk scores which help in the clinic? I think this is probably an easier task. And then given this, I think another important question is, what would you see as an ideal situation? And keep in mind that not all centers have capability to learn or teach their models in large data sets. So should you, or if we are thinking forward to the future, and when you look at smaller centers worldwide, are they going to depend on those models which were trained on, let's say, the German data sets, or should they actually teach their models locally?
Yeah, so super important issues, and I totally agree that we really have to consider this question. So I strongly believe that fine-tuning for certain, let's say, areas or certain circumstances is really it's feasible, and I think it's needed at least now. This might change, probably like 2 years ago, I would have been skeptic about having like a really precise treatment recommendation coming from ChatGPT. Now using REC, using certain other like double checking and so on, I really would say for the scenario you just pointed out. So smaller centers, not so experienced, and this is what I do in my daily life. I get a call from like a colleague who only sees like several AML patients, and once a year or every 2 years, one patient with IDH1 mutated acute myeloid leukemia. And of course, they are not familiar with ivosidenib or the data for IDH2 mutated patients with venetoclax and so on. So, and for them, it's really working, I'd say, perfectly to upload the clinical case and then get like a clear recommendation based on guidelines, but also incorporating all the knowledge which is out there, I'd say, in the curated knowledge database. So for that, clearly working, and there I see a substantial benefit for like the whole society, leveraging like all the top level knowledge which is there, making it applicable to basically every single center. So I really see a strong benefit there, and agree on that we have to like look at the data that was used for training and then talk about minorities and adjust this for certain areas and certain special situations. Yeah, really important point.
Small quick point, and I think this just illustrates the importance of real world data. I mean, I remember that several years ago, conducting research on real world experience could have been, I would say, not looked as highly because maybe, as a quality of clinical research. But I think right now, in my view, real world experiences are of utmost importance because they will be able to enable us to train those models more efficiently in the future. Aziz?
Yeah, absolutely. I mean, there's a lot of to pack. I would like to switch to AI, and I think what Dr. Ahmed was saying. If you take, and actually what Tian have shown, and we have shown before, we sort of never published this, but if you take all the clinical variables, so clinical variables, right? Age, cytogenetics in AML, and white blood cell count, LDH, all of the stuff that you use. And then you take genomics, mutation. And let's say you take 200, 300 of those mutations. You put all of those in a machine learning model and then run survival analysis and then extract the top features that what Tian was presenting. And what's interesting, and we have done these experiments on many data sets, always, by the way, clinical variables come on the top. You will never, even TP53 will never come up on the top. So you have age on the top, cytogenetics going to come up on the top. And then you're going to get a couple of other things like white blood cell count and those things. And then the usual suspects, NPM1, FLT3, TP53, going to come up as important mutations. The number of mutations always come up as important variables. And then as you dissect to the lower thing, the mutations, the other ones, becomes their impact is smaller. So some of those algorithms will come and say, if you look at the impact of age, will be huge compared to the impact of, small, maybe KRAS or NRAS or something like that. So reality is that really age, cytogenetics, and some of the characteristics going to be the biggest chunk of your prognosis. Meaning, if you go to adverse event patients, so let's say go to inversion 3 or complex karyotype, at that stage, honestly, doesn't matter what mutations they have. It just doesn't matter anymore because then the outcome is worse, it's bad, and you're going to send them to transplant. So the mutational panel not going to impact your decision-making. Because I think the AML is a diagnosis. Now we're talking about a diagnosis. You have a decision to make, right? Intensive chemo for younger patients. And the biggest decision, would I send this patient to transplant or not? That's where you're trying to stratify those patients. And when it becomes difficult, obviously, it's the normal karyotype, because then in that scenario, you have a big chunk of patient, about 50, 60%. Those you don't know where you're going to send to transplant or not, right? And this is where the decision become more complicated. And I think machine learning will help in some extent. But at the end of the day, I think it's, as you guys said, is the complexity of do you have a donor? Can the patient tolerate transplant? All of those other decisions, which, by the way, make it sometimes also difficult to build a machine learning model that have all of these aspects that you don't put in the model. This is why if you look at any survival model that I've known, machine learning, without machine learning, large data set or lower data set, the accuracy or the C index of these models typically in the late 70s. I mean, if you get a model to be 0.78, I mean, we used to throw a party on a survival model, regardless what you put. And when we get a model in the 80s, I trash the model because I know there's something wrong in this model. It doesn't respect, because you can't have all those variables in the model. So that's another aspect that we need to think about when we talk about modeling. Are we putting all the variables for the patients, not what we see in clinical variables and genomic, but other aspects that typically doesn't come to the model?
I think this opens the door also for one of the questions we had. Our friend Dr. Bassem Beiruti is also interested in AI. But I just asked a question, and I think this really opens a big question here, is that how close are we to personalized AI-based AML therapy? Let's concentrate on AML. And I want to take it from the aspect of regulatory agencies. How are we going to, how do you see the future and guiding the regulatory agencies' impact on using those models to guide therapy? Because they do, I would say, break all the traditional ways of approval. So how do you foresee that? I mean, how is it happening in Germany or the US, right?
Aziz, do you want to start, or?
You don't want me to start because I can do like 20 minutes on this. So, so it's really actually the question. So the other question that I think will be important here is, and I would love to see your take on this. To me, the aspect of AI, there's different things, right? So we can build models that, at least now, as Jan has shown, are either similar or in some aspect better than human in making diagnostic accuracy, risk stratification, and treatment selection. So that's the research part. I see the challenge here, especially as we move, as Jan was talking about, the multimodal, where you get information from different places. You have images, you have clinical data, and then you have databases that give you all of this information. The challenge is, how do we move this from research to application in the clinic? And the reality is really not about the technology. It's about, for example, a lot of centers, and I can tell you even in the United States, they don't scan the slides. So just digitalizing AML slides, by the way, outside of research and make it routine, it's very expensive, and most hospitals don't have the infrastructure to do it. So you can build the best AI algorithm that can read the slides, as Jan presented, tell you, for example, on the AML, this is NPM1 mutation in seconds, right? So you run it. You're going to go to the hospital is going to struggle applying it, because who's going to scan the slides? Do they have the workflow to scan the slides and all of this stuff? And I think that's what we need to address here. How do we move from research to application? Before even we go to the FDA and all of this stuff, application in the hospitals. And that's what I see a lot of hospitals typically struggle with AI, is really when you try to move things to be more commercial and embedded in the workflow. Either you don't have the infrastructure to do it, or you don't have the workflow, which is another important aspect. Workflow, what I mean by that is, okay, you do a slide now today, you send that to the pathology will cut the slides, the technician will do that, then they will give it to the pathologist will read it, and then pathologist will dictate the case, right? That's a workflow. Now, when you have that workflow and you embed AI in it, or you embed that in that workflow, that's also become challenged, because then human, with the new process, they get lost. So you also need to redefine what workflow do you have, and then how do you embed AI inside that workflow? And then again, add more complexity, cost. So we have seen adding AI, adding more cost to healthcare rather than decreasing the cost. So how do you address that? So would love to hear from you, Jan. How do you think about that in your hospital, outside of research, and obviously with your new startups?
Yeah, totally agree. And yeah, so maybe we start with what we did at CanSilico, where we do the AI diagnostics for hematology. So what we thought from the beginning is exactly what you said before. We have to integrate it into the workflow, and that's why we didn't go for the end-to-end approach and coming up with, this is infiltration by CLL of 70%, or this is low risk MDS. We thought, okay, we're going to do exactly what you said, the workflow. So we come up with a myelogram, and then, okay, the doctor knows, okay, this is a myelogram. I usually come up with counting cells, and now I make the report. And we believe that in a couple of years, people will accept, okay, here it's written down, this is like MPN infiltration, or this looks like MPN, or whatever. But for now, we thought, okay, just doing this step, take any picture, and again, as you said, just put a cheap camera on your microscope, as your workflow is right now, microscope, computer, put a camera on there, see it here, apply the myelogram, get the myelogram, and then you'll write your report on that. This is the way how we believe we can really get this into the clinics, and this is the feedback from the first customers that it's making sense. Totally agree. For the like big agent things, we have to like get all the APs and like our electronic health records. They're all like closed systems. I know Epic is a little bit different, which is really commonly used in the US, but this is a big issue. And yeah, you just touched upon FDA. How should we approach them? And we can't even say, okay, like we can't freeze a model. If you use a model now, and even like for the publications, once they're out, the model used in the paper is outdated. So how should you approach like an agency and say, okay, we used like I don't know, Claude with whatever or Llama, and then you have it and you have to freeze it. It's not working. And on the other hand, I see the young doctors at our hospital using ChatGPT. It's open. They have it open in their browser. And I can't even really tell them, no, this is wrong, because for so many things it's working really well to get like a differential diagnosis of a patient in the emergency room. It's working quite well. So, and we have to face this, that this is a reality, that people are using it. It's like 15 years ago or 10 years ago, where we told our patients, you should not Google. And even back then, it was quite useful, and they sometimes came up with a better differential diagnosis than you. So, a lot of questions I don't have really good answers. With the exception that I totally agree that we really have to come from like thinking in workflows, integrating it in our daily life, in our routine, not trying to change it completely from day zero, basically. And for regulatory, yeah, so many open questions.
Beautiful.
Yeah.
Ahmed, we can go for another half an hour, but I think we're up at time.
Yeah, I just want to close by asking Dr. Ahmed, Reji, since he's an excellent clinician. I always say that AI will never replace clinicians, but clinicians who know how to utilize AI will replace clinicians who don't. So how do you see that, Dr. Ahmed, right now, and from the perspective of clinicians? I mean, in the next 5 years, how do you see the acceptance of the idea of integrating AI in our workflow?
Yeah, I think, thank you, Dr. This is very important, and I think they are complementary to each other. The AI, I think a few years ago, it was like, if we say maybe it was used in 5%, nowadays we're seeing it 20, 30%. Maybe in 5, 10 years time, we'll see it like 50-50, or maybe more than this. However, the physician should be there, and it's complementary because as you saw, different mutations, different biology, and then the guidelines would not answer the question. So you need the physician to be there always, and that's why I think it's complementary, the AI and the hematologist.
Yeah, well said. Yep, I think we're a little couple of minutes above our dedicated time, but I really honestly say, and I think Aziz would share the same, I could not have hoped for any better than this experience that we had today. This is exactly what we were aiming to, and it was covered very excellently with both of our speakers, Dr. Ahmed and Jan. And hopefully the subsequent series will be as good as this one that we have today. So I would like to again thank the SFPMT, all the attendees, all the speakers of today, my co-chairman of this meeting, Dr. Aziz, and Abdi, who really showed the dedication to sponsor this session of today. So thank you very much, everyone. Have a great rest of the day. And we'll see you again in 4 weeks from now for our next session, which is going to concentrate on the clinical trial conduction aspects and the impact of AI on that. So thank you all.
Thank you. Thank you, Ahmed. Thank you all.
Thank you all.
Thank you all. Yeah, really nice. Thank you. Goodbye.
Goodbye.
Bye.
Yeah, how was it?
That's great. We got almost 140 plus people. That's excellent.
Yeah, that's